All right, everybody. It is just at the top of the hour on this Thursday, the 12th of May. I think we're going to start soon, and we usually take a little bit of time to talk about announcements. It is a glorious spring day here in Vermont, where I am based, and it's a riot of flowers out there. I hope it's lovely wherever you are too. So again, welcome to the May 12th public call. We have some voting to do. We have some review of two domains to go over. We have tech and policy updates, and we're very glad you're here. Again, my name is Sarah DeSilvi. I'm the Director of Terminology for the Gravity Project, and we will kick it off. Next slide, please. We want to thank you for joining. We always mute everybody upon entry just because usually by the end of the top of the hour turnover and attendance, we have about 100 folk. All of our calls are recorded. So if you want to find the call after the fact, they'll be available on the Confluence. We do take great care to work the chat feature of the WebEx. So if you have any comments that you want to have be part of the conversation, any comments on whatever we're presenting, just send a chat to everybody and we'll work it into the meeting. All right, next slide, please. This is a standard practice antitrust practices slide. This is a requirement for our gathering, just reminding that everybody has to, as part of this project, has the responsibility to comply fully with federal and state antitrust laws. Next slide, please. And then this is our slide on project participation. So we are a member organization. So we invite everybody to officially join the project. Joining the project allows you to be part of our communications and a part of our voting. If you want to check whether you've already signed up or not, you can do so on the Confluence as well. And then the Confluence in general is just a bevy of activity on everything we're doing across all of our different work streams. So you're welcome to follow that at the last link. A specific thank you to our project founders, grantors, and in-kind support folk. We, again, have support across of our ecosystem, both in financial and in-kind. Very, very grateful for all of the folks who help pitch in to our collective labor. Next slide, please. One of the things that we mentioned at the last call, which is the truth right now, is that we are not an entity. We're a collective and a project funded through stakeholder sponsorship. And we raised at the last call that we are currently facing a funding gap, and that funding gap required prioritization of activities. And we wanted to just make sure everyone's aware from a transparency perspective that prioritization may affect meetings and events in the coming months. And I wanted to state very clearly that in our prioritization, the priority at the heart was to preserve the collective work of our domain work and this public call and the completion of STU2. This is the heart of what we do, and we want to make sure that everyone is aware of that. The principle of supporting this collective domain work and this public call and STU2 balloting are echoed across our committee structure, including our executive committee. The intent of tightening our belt a little bit is just preserve and extend our runway of funding so that we can rally and get more funding and head into the fall with full activities and fully funded. It's just in light of that, it's more important than ever to direct any sponsoring activities to Gravity Project at emiadvisors.net or visit the Confluence site to learn more about sponsorship. We very much appreciate everyone is able to sponsor, whether it's labor or financial support, including if anybody has any ideas, just let us know through the email, and we would love to follow up on them. Any questions on that first lead in? All right. So this is our agenda for today. So we're going to go through some announcements, run through the project schedule and overview. We then have our first consensus vote of the spring domain series. It's on her health literacy work. Then we're going to go through some updates and end-to-end review on health insurance coverage status and medical cost burden. Mark will give a policy update with some exciting policy updates, and then Greg will close with technology update. Next slide, please. All right, announcements. So I'm going to try to do some of these. If we have colleagues on the call who can help pitch in, that's lovely. But we've been talking ongoing about our partnership with the CDC on the SDOH Public Health Use Case Work Group. That work is kicked off and doing wonderfully, and you can find that work on the Confluence. We're very, very grateful and excited about that work. So there's basically a sister public call that happens to the CDC that you can participate in. And we really want to make sure that as many people as possible join that work to help the CDC forward this important use case development. We also wanted to make sure that anyone who's interested registers for the ONC Social Determinants of Health Information Exchange Learning Forum. That has also been kicked off. There's many friends in that work, and it's another wonderful place to share wisdom and thoughts about the work that we're doing. There is a White House conference on hunger, nutrition, and health in September. There's also the announcement that we gave last time on the White House's announcements about the 5 life experiences for collective focus and improvement. All of these announcements and more are available on the Confluence, on the Gravity announcements page, and you can find them at the link. Remember, for most links from WebEx, you need to click twice to get to them. So if you have a hard time getting it to it once, just click the alert the second time and you'll get there. Any other questions on the announcements? All right, next slide, please. So this is our Gravity 2022 roadmap. So we are here in the middle of May, or just about the middle of May, about to vote on our health literacy master sets, closing out health insurance coverage status and medical cost burden. We did mention at the last meeting that we are, again, prioritizing our domain work and looking forward, if all goes well with funding, to kicking off food access, neighborhood safety, and digital inequity in the fall. Just a reminder, the digital inequity is a combination topic of 2 different elements. One, digital literacy, that we've really elevated from our health literacy work, and then digital access, which ties in neatly with our community domains in that set. In our technical work, we are working on the STU ballot reconciliation, and we are planning for our CMS Connectathon. For participating in the CMS Connectathon, Greg will talk more about that later. A reminder that in general, our pilot affinity work group is on pause because it was one of the things that we had to tighten in our funding gap, but those contracts for the pilots directly are continuing, and we're looking for ways to try to make sure that work is transparent to the public collective. Any questions on the roadmap? All right. And next slide, please. You're always encouraged to actively participate and use the WebEx chat feature just to send, and just so if you have comments or questions later, we can always cycle back. All right, next slide. I believe I'm passing the mic off to my dear friend. Next slide. This is what we're calling Linda's Corner. Linda, hi. Would you like to take it away?
Sure do. Sure will, Sarah. The first slide, as you can see, we're really excited about the number of SDOH terms that were in the fiscal year 2023 inpatient prospective payment rule. We have separated them out here. The first group are the ones that Gravity has submitted, and there are a couple others that were submitted by other organizations that also relate to SDOH. You can see here from the list that this will round out a number of the diagnoses for our earlier domains that we first worked on, coupled with what came out in October. These will be available as of October 1st discharges. And obviously, as soon as they're available and in VSAC, we will start updating those value sets that they will refer to. This is the list of codes that are final to date based on what was available at the time of the Federal Register. There may be additional codes that come out, but there are likely not going to be any diagnosis codes. Usually that's for last minute procedure codes that we're won't be completed until after the proposed rule came out. We'll see the full set of codes in the addendum, and that'll come out sometime in May or June. And from there, we will be able to start updating some of our master lists and getting ready for October when we can put everything in VSAC. Next slide, please. And I also wanted to update you about VSAC. We had the March SNOMED release contained a number of gravity submissions. So Hamali and I were busy updating VSAC. These value sets are going to be available, I believe, tomorrow. I think we have them all set up as ready to publish. There are new value sets for the less than high school education for diagnoses, financial insecurity, and transportation and security interventions. Those are brand new. And for updated ones, we got additional diagnoses and interventions for the domains that you can see listed there on the slide. The next SNOMED release will be in September, and coupled with what we are expecting from the previous slide for ICD-10, we will be starting another round of VSAC updates mid to late October. Any questions? If not, I'll turn it back to you, Sarah.
It's a quiet group today. I did want to give a nod that Tom's talking about the proposed 2023 SDOH. I know, it's so exciting, Mark. The proposed 2023 SDOH HEDIS measures, and I just want to give a deep thanks and appreciation to our NCQA colleagues, and we work very closely with them on alignment with the gravity terminology elements. So I'm thankful for their work and collaboration as always, and the NCQA is involved across our system and our various committees, both the SAC and the TAC as well. All right, so this is, you can see the dwindling calendar because we are, our new model is to sunset and do a little bit of private work, 2 months after each of our build periods. So we did this in January and February. And then we do it again in the summer in June and July. Yes, if I have that correct. I do want to note that part of what we're going to be, we usually spend that time in education and dissemination, trying to get our works out to the public, but because of our funding gap, that work is quieted. So we'll be a little bit more quiet than usual in June and July. But for right now, here we are at the health literacy consensus voting, and one last review of our medical cost burden and health insurance coverage status elements. And then at our next meeting, we'll reconvene and have the consensus voting for that for our different sets. It's pretty exciting, and you've all done a lot of work over the course of the spring, and then we look forward to reconvening in the fall to address our fall domains. And so here we are. We haven't done a vote in a while, so heading into the vote on health literacy. Next slide, please. Next slide. So there's very few little things to update here. So we're just going to go through, some elements just for everyone's information, and then we'll close with the vote. So the definition of personal health literacy has not changed. Next slide, please. Definition of organizational health literacy has not changed. Next slide. Our screeners have not changed. Those are there, and all of these again are found on the master, so you can see any of these screeners and the questions therein and the answer sets all contained on the health literacy master file. Next slide, please. Due to all of our collaboration, we have come up with this set of new diagnoses codes. Again, the SNOMED CT code exists. The new ICD-10 code we'll be recommending is problem with health literacy. This aligns with an ICD-11 code that's already available in the international ecosystem. And then we do have these elements that we worked on, really trying to center the responsibility of the organization in the presence of personal health literacy. So not just centering all the focus on the individual, but how do you represent organizational level responsibilities to the person? So all of these terms have not changed. We've tweaked them a little bit, but there haven't been any changes since we last gathered. Next slide, please. This also hasn't changed, so we worked on this together, our health literacy goals. Again, you can see in the goal we crafted over the course of the last few months, the fundamental principles of health literacy contained therein, right? Has access, which is part of that responsibility to the person that the system makes it available. It's understandable and useful. Again, those are the core principles that course through that personal health literacy definition. And then it's able to be applied, which is you're using it to inform health-related decisions. So this is a goal that we all collectively came up with. There were some submissions from the community. They were refined in our conversations and brought back, and we're very grateful for the collective work here. Next slide, please. These are our health literacy interventions as they stand right now. I do want to get to point out two kind of late breaking thoughts that came across the pike. So one, our dear friend Tom Page submitted a submission for health literacy in alignment with 211 LA. When we get to the voting, we will discuss how yes with comment can be a late breaking idea. We've done such great collective work that this set is really pretty robust, but we're going to integrate, or we're going to review some of Tom's comments really about those 211 LA alignment when in our review of the voting process, and we'll talk about that going forward. And I also wanted to raise an email that we got from Matt Bishop, specifically aligning on disease-specific education and its intersection with health literacy. So one of the things we're considering as we go forward with the vote and the reconciliation of our votes is how to address any disease-specific education, like referral diabetes educator or referral to the YMCA pre-diabetes program. So these are all things that happen really disease-specific as opposed to general. And so we will be trying to figure out how to include some of those elements. Luckily, there's a lot of education structure and terminology already in SNOMED CT and already in VSAC. Again, a lot of those education elements align with existing quality measure reporting. So whatever we build, we promise to build efficiently without overloading our set, but really to try to create a pathway to whatever disease-specific or condition-specific education might be appropriate within the domain of health literacy without taking us too far afield into those really disease-specific conditions. Like, because in the line of care, when I'm doing an intervention on a new diagnosis of diabetes, that intervention is actually driven by the diabetes diagnosis, and et cetera, across all kinds of conditions. Whenever you have a new condition or a knowledge gap, you do try to address it usually based on the diagnosis itself. However, we really want to honor the fact and support, and we're just very, very grateful for Matt's email. And we're going to see how we can integrate some high-level kind of general codes regarding disease and condition education in order to make sure that our set is robust. Any questions on what I just said? I talked about final updates because of possible opportunities to align with 211 LA, and some final updates to consider how disease-specific education at a high level, codes about that really high-level disease and condition education might be crucial for this health literacy intervention set. It sounds like, Matt, is that a good answer to your question?
Yeah, thank you so much for considering my recommendations on this. Thanks.
Of course, Matt. Thank you so much for bringing them up. And then Tom, does that sound good for you? If he's on, I think Tom is almost always on. Tom's there. Tom, sound good?
Yes, no, it's great. Thank you.
Okay, wonderful. I want to just is there a process underway to ensure ongoing alignment with 211 LA taxonomy? There is. I do want to state that in the past, we've had a specific contract with colleagues within 211 to ensure alignment. Due to some of our funding concerns, that's one thing that has not been elevated, but we do recognize the importance there. I do want to give a specific shout out to Tom, who always does really yeoman's work in this space because of his own expertise in 211 LA, but we have had contracts in the past to ensure alignment with 211 LA, and we do ensure that we are mapping at all times to the elements of the 211 LA taxonomy. Yes, it does. 211 LA has tons of disease-specific services, tons. Yeah. So I hope that answered your question, Art. Very grateful for all of our friends across the 211 ecosystem because it's absolutely critical in the medical social care integration space. All right, next slide, please. I'm just going to pause. I want all of us to collectively honor the fact that we just completed a lot of labor. Like that, the health literacy master file as it stands right now is a pretty wonderful achievement. It represents lots of really critical data elements, and I want us all to just be like, honor that work that we've done together over the course of the last few months. I'm very proud of you all. I'm proud of us, and just thank you for participating in this work. Again, thanks for every single comment, every comment on a public call, every comment on an email. This is really what makes us who we are. So this kind of collective work toward improving SDOH data and terminology. Okay, the consensus vote. We haven't done this in a bit, so I'm just going to review again. If folks can mute if you're not talking, just because there's a little feedback, that'd be great. Thank you. If we can go back one slide just to review the voting elements. So there are 4 possible voting possibilities. Yes is a yes vote does not necessarily mean the deliverable is the ideal one from the perspective of the committed member, but it's better to move forward than to block the deliverable. Yes with comment is what I was speaking of as an opportunity to send kind of late breaking thoughts, right? And this is in light with what I was talking with Tom and Matt, right? So if a consensus process attracts a comment through yes with comments, it's expected the comments will be addressed in a future revision of the deliverable. So yes with comment is, I support this and I have these thoughts. Any yes with comments needs to have an email sent to Gravity by a week from now, so 5/19/2022. You just send it to the Gravity Project at ENMyAdvisors.net, and we resolve all comments formally as part of our process. Everything we do is transparent, it's all trackable, and we reply to any email comments that we've received. Similarly, there's a similar requirement if you're making a formal objection. We've collectively done this work, so a formal objection really needs to ethically honor the work we've done together. So it has to include a comment indicating a path to address the objection in a way that meets the known concerns of other members of the project. So you can't just object, you have to object and say, this is the path forward, right? So a formal objection vote without such comments is considered an abstention. So if you are formally objecting to the master list, you email the comments to gravityproject@ENMyAdvisors.net by 5/19/2022. Again, note that both yes with comment and formal objection are ways to make statements known, right? And they're ways to ensure that we listen to your concerns as we always do. The final way to vote is abstention, is a member declined to vote. Oh, I'm sorry. Can anyone hear me? Can people hear me? Is
Yes,
Dorothy?
we're fine.
Okay.
Sarah, yes.
We can
Wonderful.
hear you.
Okay. Okay, good. I saw Dorothy's statement and I was worried that it was a universal statement. So thank you so much. Wonderful. So now we're going to go on to the next slide that goes into further details. Next slide. So as usual, and I want to give great credit to the amazing Sarah Bahal, who's part of our terminology and Gravity team, because she created this whole process. And she is the kind of brains behind dropping all the links in the chat. Just super, super grateful for Sarah Bahal. She's amazing. The way to vote is you complete the following Google poll by 5 p.m. Eastern Standard Time tomorrow, right? And maybe you should do it today because tomorrow's Friday the 13th. But you complete the following Google poll. It's going to go on the link and in the chat. And I want to note again that sometimes when you pick up elements within the WebEx chat, you have to click them twice to get to the link. We're only voting on the health literacy master file right now, and we want to just state very clearly that if you have any problems accessing the Google poll, you can email us. If you want us to do a direct send of the Google poll to you via email, we can do that. We are here to assist you. Again, it's always just gravityproject@ENMyAdvisors.net. Specific elements, you need to press submit for answers to be recorded. It's at the bottom. And then again, any of those comments, either yes with comment or formal objection, you need to email those comments to gravityproject@ENMyAdvisors.net. Any questions? Wonderful. Thank you, Sarah. So in the last, like since 414, at 414, Sarah Bahal very kindly dropped the Health Literacy Master file into the chat if you want to give it one final review. And she just dropped in the Health Literacy voting poll link at just now at 4:25. So I'm going to give a little pause if anybody wants to gather that, just to make sure everybody can get it. And again, if you can't get it and we move on, you can find it up above in the chat, or you can email us and we'll get it to you. Any questions on the voting process? What the 4 different voting elements mean? Okay, I think we're getting this down by now, 3 years in, or whatever it is. It's been 3 years. Wonderful. Again, just really grateful for all of your work on this health literacy set. I'm super excited about the work that we did. And I've been telling anecdotes all along about how just learning about health literacy with you all has informed my daily practice as rural family medicine. And I just cannot wait for these terms to be available if all things go as planned and we're able to advocate for them being into the ecosystem. All right. Next slide, please. Wonderful. Next slide. And again, if you have any problems accessing the poll, just write us. Very few updates regarding the next 2 domains, but we are going to head into them now. So we're shifting. We're going from voting on our deliverable, our final set with health literacy, into review of our other 2 spring domains. Do the value sets get updated in VSAC each time SNOMED updates? If there's new concepts, are these updates based only on the US extension versus each SNOMED international update? So value sets do get updated into VSAC each time SNOMED, not each time, it's like twice a year that we do it, right, Linda? Is it twice a year or 4 times a year? I'm suddenly...
It's twice a year, March and September for SNOMED and October for ICD-10.
Thank you so much. And then any of the terminologies that are within our value sets, whether they be international or solely US extension, if they're in our master list and Gravity helped advocate for them, they are part of those VSAC value sets. Many of the terms that when we build with SNOMED CT, we have both international representatives and US representatives at the table, because many of the terms that we elect, especially if those domain diagnoses level terms, are eligible for international SNOMED CT. I do many of the interventions specifically because they align with US policies and processes are solely in the US extension. Thank you, Lucy. All right, end-to-end review. So here we go again. So end-to-end review is a time to step back and consider the whole set and ask questions. Are there missing concepts? Are there incorrect concepts that need to be changed? Are there concepts that are unnecessary and should be removed? Comments and edits must be offered in written form with a rationale and evidence for suggested alternate approaches. It's the same principle as I was saying as the formal objection. We are doing collective work here. This is the final kind of kneading of our work. So if you have thoughts, we really need a rationale and evidence. So often we reply with, give us a use case or give us a definition. So if you're submitting end-to-end review comments, really try to think about what is the use case for the additional element and what is the rationale for that additional element, and that kind of saves back and forth. Okay, bye, Mary. Could someone point us at the specific publication schedule, e.g. what dates in March and September for SNOMED, what dates in October for ICD, and is there a specific publication date for changes to LOINC? I don't think we have, they all just changed. So we do know that ICD-10-CM is October 1st. And then, Linda, do you want to speak to the possibilities for the other 2?
SNOMED, it looks like it's at the beginning of the month. So like 1st of September, 1st of March. LOINC, I believe, it varies a little bit. It may be in the middle of the month, and they are in March and August.
I realize this is a challenging thing to wrap your head around as a human being, but I want to tell a computer when to go and pull the latest publication, and telling my computer to do it near the beginning of the month is not quite as beneficial as being able to tell it, yes, on the 3rd of every month or the second Monday of September or whatever.
Oh, so Brian, the problem is that there's the releases of the terminology, and then there's the human labor as Gravity as the curators of those value sets. So I just want to make sure that everyone's aware that it's human beings. It's really Linda and the amazing Hamali, so Hamali and Linda, that update those value sets within VSAC after the terminology is released. So there's often a delay. So I just want to make sure that everyone's aware.
Okay, I'll try to get my computer not to give you human beings a hard time.
Okay, that sounds great. Matt's asking a question regarding N10 review. So N10 review is not about health literacy at all. We just voted on health literacy. We're heading forward into health insurance coverage status and medical cost burden. And certainly if you have an element of the IG, that's best to submit it within the Gravity Project at emyadvisors.net. Or I believe you have friends in the technical advisory committee who can elevate things about the IG to that committee and make sure that we have them there. And then if you have elements about the structure of the value sets, send us an email as well. So suffice to say, Matt, if you send us an email to gravityproject@emyadvisors.net, we will ensure that your thoughts are sent to the correct place to make sure that they're addressed. Is that helpful?
Yes.
Wonderful. Okay. All right. So heading into end review on our 2 elements. Next slide, please. Again, very few updates here. So our general interventions, we did want to make sure that we let everybody know that these are the things that carry on across different domains. So they're always in whatever sets that we have. And again, they're diagnoses neutral. So whatever diagnoses, whatever domain you might have, they are always going to be able to apply usually. Next slide, please. These are also general interventions that we put into all of our domains, usually to align with care planning activities. Next slide, please. And then next slide. Health insurance coverage status. Again, just example questions. These are from NHIS. So again, if you go to the health insurance master file, you can see a tidy set. It's slimmer than many of our domains, really specifically because it aligns almost universally with federal survey methodology because it's very straightforward. You can remember that the veteran status elements and the education elements were very similar. They weren't as robust as some of our other elements insofar as the screening questions and answers that get you there. Next slide, please.
Sarah, thank you for adding all that military stuff.
Oh yeah, we have a specific element on that, Lucy, and now thank you for raising it as always, right? So these are some of the health insurance coverage status screening tools that are there. Again, NHIS, FNX, and Prepare. Next slide, please. And then these are some of our diagnoses terminology we're suggesting. There are some missing elements on, I'm sorry, if we can go back 1 slide, I apologize, Demery, I'm messed up. 1 more slide, if we can go back 1 slide. I wanted to just, amazing Demery's helping us today. Thank you, Demery. There are some elements from our survey of federal screening tools. Again, we've been talking about this as we've been going on in order to ensure really just standardization and alignment across all of our different use cases, including research. Our team, again, really mostly specifically driven by our colleague Hamali on our terminology team, have been assessing all of the kind of standard survey approaches, including the American Community Survey. And there are some, medical expenditures survey, and there's the National Health Interview Survey. So there are some questions in queue to possibly go onto the health insurance coverage status screening tool section that you may see before we get to vote next time. So there might be some updates to the screening elements master file shortly. Again, Hamali, thank you for leading that work and doing that work so diligently. We have many requests to ensure we align with the American Community Survey, and we did recognize that we needed to make sure we align with all of the federal approaches. So she came in and immediately set to task on that. So grateful. Next slide, please. So This is our unchanged, our recommendations for diagnoses, really just creating a specific ICD-10 CM code for insufficient health insurance coverage. The existing term that was there was really way too bloated and nonspecific, and really aligned with kind of international ICD-11 as opposed to appropriate for ICD-10. And so you can see there's a what's in bold again is already what exists there, and then there's the terms we're recommending. Next slide, please. We have added, so again, Lucy, not in incredible depth, but there's a specific slide on the military and veterans health insurance coverage. Again, this is the goal statements would be the opposite of the problem. So it's the presence of the insurance. So again, everything in bold already is in SNOMED CT. So you can see the last time we met, we had this non-bolded has health insurance coverage. Our audit really of NHAS, an existing, the American Community Survey, an existing survey methodology, and existing insurance types, had us add 3 other elements already off the cuff, right? So child health insurance program coverage, Medigap coverage, and Indian Health Service coverage. We were remiss to not include these prior. They are not in SNOMED CT. Again, these would only be appropriate for the US extension. And then next slide, please.
Sarah,
Hi, yes.
just a question, maybe someone else on the call can comment on this too. Indian Health Service coverage. Is Indian Health Service insurance, or is it something that you can walk in and get if you can prove that you're in a recognized tribe?
It is both coverage for the care and access to the care. So it's like it's as if it is a insurance coverage type according to all of the federal survey approaches, right?
Okay.
And so
You actually you might actually have a card, like you have a Medicare card or Medicaid card. You can have Indian Health Service card.
you can have insurance, you have Indian Health Service coverage, yes.
Card.
A card, and again, I don't want to speak out of hand. If you're looking for whether there is a specific card, we will reach out to our IHS friends to make sure that we answer that correctly. I don't want to speak
I'm
incorrectly.
just, okay, if all the federal government considers Indian Health Service to be coverage, the same as Medicare or Medicaid coverage, I certainly can't argue with that. I just wasn't aware that this was health insurance, where you go in and you might have a copay, but there's an EOB that you can look at and get the services in it.
Lucy, like you can imagine, like this has been my experience anyhow. There are hundreds of tribes, and each of them have unique aspects about the community care they provide as well. So it's not like everybody gets issued IHS insurance card, per se. There's other care that they're eligible for, and that their community, the tribe, pays for as well. So hope that helps. I'm sure there's a reason you're asking.
So it's complicated. Okay.
It's very
thank you.
complicated. Yeah. There's a whole bunch of different, every tribe is sovereign and makes their own decisions, right?
But does every tribe determine the scope of coverage within the Indian Health Services facilities and resources within their boundaries?
So Lucy, can I recommend that we get a specific response from our colleagues at IHS regarding
Okay.
this matter?
Okay, thank you.
Just for
Oh,
sake of
fine.
honoring expertise.
Great.
All right, so Kate, thank you so much. And then Tui has the PIV card, and then Jim is saying yes, and they can use the ACA marketplaces too. So maybe we have sufficient answers. I just want to make sure that we're not misrepresenting anything. Anyone have any specific statements they want to raise on IHS before we go forward? Matt, looks like you have your hand up.
My comment is about a different topic, but
Okay, so Toya, Jim, Kate, anybody want to make a final comment on IHS? It looks like it looks like we're good. Wonderful. And then maybe we can make sure that that's part or the answer from IHS is a response within our community email prior to the vote next time, just so we get it on the record, Lucy. Sound good?
Yes.
Yeah, sounds great. Thank you. And then Matt, you have another question?
Yeah, so oftentimes, like, just because someone has access to coverage like Medicaid, for example, it doesn't mean that there's a provider who lives nearby that accepts Medicaid. And then, so I'm guess I'm asking about this kind of, it seems to be kind of bridge material hardship and more like access to care either regionally or in a state, you know, especially when so I don't know where that would fit if you were finding someone couldn't get care because there just weren't providers in the area.
Yeah, so Matt, so under our specific topic in our agenda really centers on the reason why we're doing health insurance coverage and medical cost burden, really centers on trying to unpack some of the confusion that was created out of a submission to ICD-10-CM last year that conflated the terms incorrectly. Our general topic, if you had access to the comp ones, you would see it's under healthcare access.
Sure.
Which under healthcare access, there are many other subtypes. There's like PCP access. There's like
Okay.
so all of if you look at the Healthy People 2030, there are under the health access bucket.
Great.
There are many questions that are in line with healthcare access, of which this is only one type.
Great.
Yeah.
All right. Thanks for clarifying.
Awesome. Thank you. Okay, any other questions on this slide? Perfect. Okay, next slide. I just want to give a specific shout out to Charles, from our friend from Perm. I feel like he really is so helpful. So we had a task, we recognized very clearly, and this is again, thank you, Lucy, for calling these things to light, that our existing set of really goal statements, our presence of insurance statements that you saw on the last slide was incomplete when it came to representing the members of the military, the VA, or the National Guard. So if we can go back, this is the statement. If we can go back a slide, Demery, and I'm really, thank you so much. So Veterans Affairs health insurance coverage is there. So many elements are not there, like TRICARE is not here, et cetera, and many other different types. So we really are trying to create a structure in order to build these terms into SNOMED CT because there's some overlapping elements. Like there's some types of TRICARE coverage that are used within members of the National Guard. So I can promise you that in very short order, we will have kind of an updated statement. It really probably was going to include general like coverage by military military health insurance coverage statement, and then statements under it. So you can press that easy button if you want to, and then you also can divide as different subtypes. We're always trying to be frugal in our build, so we are working with Charles as well to understand the use cases for any of those more specific elements within SNOMED CT. So after the call last time, we did reach out to Charles. We've been going back and forth in emails, and I do feel we'll be able to come up with some terms that you'll see on the master file very shortly. Wonderful. All right. Any other? So Teresa, if you have a question, again, you are an amazing, so I want to thank you, Teresa, for always having great ideas and submitting via email. If you can submit that via an email, that'd be great. Just to make sure you have high risk pool plan state coverage. There is currently, if you look at the NIHS questions that are the example questions on our screening slide, there is an other state health insurance coverage or other state health coverage, which that might be applied, that might be applicable for. But if you can submit that in, that would be great. All right, any other questions?
Sarah, just quickly in 2 sentences, why is it needed? Why do we distinguish Medicare Advantage from Medicare?
We distinguish it because, well, I have to be very clear. We didn't distinguish it. It already exists in SNOMED CT. So this is it's just there. So because it's there, it's reasonable to include. but we didn't differentiate it, nor is it differentiated within our questions and answer sets, but one could. And there are different benefits as well. But again, with this terminology,
There are definitely different benefits and definitely network restrictions, but the same is true for a lot of Medicaid, at least in some states. So
correct.
that's why
As
I
a
was asking the
Vermonter, I can
question.
testify. Yeah, Vermont has incredibly robust Medicaid. Yeah, so the reason why it's there is because it was there before.
It's always there.
Yeah.
Okay, thanks.
The health insurance questions we're asking are really about health insurance specifically and not oral health insurance or dental insurance, which is incredibly sad. We do recognize that dental insurance is really, really critical. We're also grateful for all the work that's going on in the policy space to make sure that it's part of Medicare. However, the question and answer sets you'll see really are on health insurance specifically. I hope that that's an answer to Kate Jenkins Brown. Dental coverage is a wonderful domain for future reference, though. It would still be under the health access element. And it's also part dental access to a dental home is also part of many different quality measures.
Also, eye care coverage for the future.
Correct. Yeah. So Jim's asking, Loincatzy's insurance type seems to be part of the FunX toolkit. Is there a reason to look at it for SNOMED CT? And that's really part of our model, Jim. So whenever we do build primarily our goal statements within SNOMED CT, even though we do look forward to building them in Loinc as well. So we're just going to have mirroring answers within SNOMED CT. And many of these are already there. Everything in bold is already there. All right. Any other questions? Okay.
Well, Sarah,
Yes.
Medicare coverage. Does anyone distinguish Part D drug coverage? Because you can have A and B, but maybe not have D. Does that matter? Or am I wrong about that?
That is absolutely true. Our current question and answer sets don't drive to that level of granularity, but if there is a use case for including a specific, Medicare pharmacy coverage goal type, because the question and answers we're asking is, do you have health insurance? Yes, no. They do not ask, do you have pharmacy coverage, right? But if we feel like that's important, again, submit an email review comment and say, because again, is something missing? Is something wrong? Is something too much and has to be removed? There's those three review elements. So if someone feels like prescription pharmacy coverage needs to be added, just send it along with a rationale. All right. I think we're good.
Hi, Sarah.
Hi. Is that Corey?
Sarah, this is Corey. Hello.
Hi, Corey.
Quick question. Just following up on something you just said, and I want to make sure I heard it correctly. Did you say you're adding the same concepts to Loinc and SNOMED? And if the answer to that is yes, can you explain a little more why that is?
Oh, no, I didn't say, sorry to be confusing. Oh, Corey Smith, critical member of our technical team. No, so there was a question in the chat about why we were adding to SNOMED CT if these terms existed in Loinc already. And I said we were adding them to SNOMED CT because that's part of our model and that's our primary driver for goals. We have talked in the past, though, about building goal statements in Loinc. That's just not our focus right now. That's what I was meaning to say. And if I confused it, I'm sorry.
I understand. Thank you.
You're welcome. And so Smriti's asking us to elaborate Indian health service coverage. Is there something further we need to say? Because we have been talking about it. It is a specific answer within federal surveys of health insurance coverage types. We've been talking about how one would represent themselves of having Indian health service coverage, and we did make it an action plan to reach out to our colleagues at IHS to give a specific statement about the use case for IHS being included within the set. Is that a sufficient answer?
Thank you. Can you hear me?
Yes, we can.
Oh, perfect. No, that was good. I was just curious, was there any metrics as to why this is more focused on the Indian population as to what it was before to what we're aiming it to be?
I'm not sure I'm understanding your question.
Sorry, I was asking, is there a specific reason this is being brought to the table? Are there some metrics on the terms of coverage the Indian population is currently receiving, is the question?
I think the reason why it's here is this is the primary way many of our indigenous populations within the U.S. receive healthcare. So
Okay, so that's the thing. Maybe I'm misunderstanding this. So Indian versus Native Indian, there's a little bit of gap there, right? So I was assuming it was just the Indians from India population, not the Native Indians.
oh yeah, no, my apologies. No, it's actually the Indian Health Service coverage, which is part of IHS.gov.
Okay, got it. Perfect. Thank you.
Yeah. All right. Any other questions? Okay, so moving on. So that is to be determined. I talked about reaching out to our IHS friends to give the use case and how it coincides and why it's part of the ACS and all of our federal survey approaches. And we are going to, we have a lot of effort already built into building those military and VA coverage types that we'll make more robust before we head into the vote. All right, next slide, please. And next slide. All right, so here we are in medical cost burden. Again, these elements haven't changed so much, but there's a little bit of a clarification on the next slide. So next slide, please. I did want to, this is a slide we presented at the last call, which is basically kind of differentiating medical cost burden from medical material hardship. So these are the bullets we presented at the last meeting. Not being able to obtain healthcare needs and services due to cost, which is medical material hardship, means I don't have it. Does not mean one has the debt or strain from accessing health needs and services, which is medical cost burden. And that pulled some of the terminology we were talking about from our value sets. And I said I would come back and I bring back a Venn diagram. I don't know if it's helpful, but this is on the next slide. Right, so I tried to lay out the stories that would drive these two answers, right? And I think it's really important to note that medical cost burden, as it exists in our model, is really a subtype of financial insecurity. It always has been, right? So if you look at the inclusion terms for our submission of financial insecurity to ICD-10-CM, it is a specific type of financial strain. I am financially strained because of my medical costs. Whereas medical material hardship, I don't have the thing, is a specific subtype of material hardship, which is not having really critical social, recognized social needs, right? So the medical material hardship element is I cannot afford care, medications, procedures, tests, or equipment. Therefore, I do not have them. I cannot afford my insulin. I do not have it. I go into diabetic crisis. I can't get the stress test. I can't afford it, and therefore I have a massive heart attack and get admitted to the hospital, right? So I can't afford copays, and therefore I'm not seeing the doctor. I can't afford my labs, and therefore I'm not monitoring my condition. So medical material hardship, again, is a subtype of material hardship. I cannot afford it. I do not have it, right? Medical cost burden is a subtype of financial insecurity. I need these things. I acquired them. I acquired care, medications, procedures, tests, and equipment, but I do not have sufficient money to pay for them. Therefore, I'm struggling to pay copays or my debt, right? So these are the things that we see, like individuals getting discharged from the hospital with extensive medical debt, and it's the primary driver for like bankruptcy in the U.S., right? The significant debt to the person, which is all attributed to medical costs, right? Or having to pay off your copays over time, right? So this happens in my old clinical situation. I have patients who were self-pay, right? And they are on very limited financial means. And so they would pay for their visits over time and then just see me once a year. It is possible that patients will have both, right? Again, both of these terms that we just saw are going to be in the ecosystem in October, right? So it really depends which one you diagnose, really depends, or which one you create a driver for is really which one the patient elevates as a need, right? So, yeah.
Sarah, I think if you're a provider like a hospital, your eligibility for charity care might be triggered by either one of these use cases. Is that true?
That is true, usually.
Okay.
Yeah.
I think this is a very nice distinction. I'm just wondering how significant it is if you're a clinician and you've decided one or the other and you put it in the record. Does it really matter for the patient which of these you choose? Picking up on Mike's email here or
Well,
Luke's chat.
yeah, so if I can think about it practically as a family practice clinician, I'm really critically worried about the fact that my patient doesn't have insulin because they can't afford it, right? They don't have it. They are at risk of having going into like DKA and going to the hospital, right? And then the risk of not being able to access healthcare and being hidden unwell is a different risk than accessing the healthcare system and needing to get support financially, right? Those are they're two very different risks with very different outcomes, both clinically, right, and mental and like from a mental behavioral health standpoint. So it doesn't, I mean, I do recognize that they overlap. We always talk about the fact that I am the Venn diagram of all of my needs overlapping. Really, whatever choice, whatever diagnosis you choose depends on the primacy of whatever's being raised in the moment. And I do want to state it's very complex to diagnose things anyway. Like the DSM-5 and like psychiatric conditions are overlapping as well. And so that's just a complexity that's part of our work. And this is the great thing about testing, right? So we're making hypotheses. We're making hypotheses on specific domains because those specific domains are measurable and discrete and different. We might not be making the right hypotheses, right? And so we look for our friends in the ecosystem to test this terminology and make sure it's clear and effective and useful. The great thing about the gravity model is there really are specific questions that take you to the specific diagnostic outcome. If you ask our questions from our medical material hardship set, they take you directly to this, like question 14 of prepare, not being able to have X because I can't afford it, or the medical cost burden financial questions we have in our current use case.
So this is Mike. Let me give a quick example why I'm struggling with this so much, because I hear everything you're saying, Sarah, but I can give you a list of patients that may start as medical cost burden that becomes quickly medical material hardship. And I think that that is a pathway that many of the care coordinators, complex case managers, social work folks that may be assigning some of these codes if I don't, are going to have some trouble figuring. I can't imagine that we're going to get this right. And if we're using these for policy purposes, I'm a little worried about the signal to noise ratio and the errors in coding these things. So I get that these are different concepts. I'm just struggling to figure out how, with all the nuanced understandings of how cost burden leads to material hardship, we're going to be able to be consistent with it. So it's a TBD. I get why we'd be doing some field tests, but this one bothers me a little just because I'm concerned we're going to get bad data.
Bad data because of?
Because we will call something cost burden when it's really material hardship or vice versa, or we won't code both when one leads to another in a chain of events. So this is a TBD. I'll hold my skepticism. I'm just notching my concern here. That's all.
I think it's important to raise those concerns, and we'll definitely test it out. Again, I do want to state I mean, this is partly why it's sad that our education dissemination element is on hold, right? And again, it requires a lot of work to make sure that we implement this well. But we really look forward to the learning ecosystem and seeing how these terms are, how they're used. Again, I do feel like the specificness of the questions that lead to these outcomes, I hopefully are assist, right? So that we can make sure that there are supports to try to get it right in implementation.
Sarah, I wonder if it's too hard to think about. I have coverage but I have a medical cost burden because the copays are too high, and so I'm not buying my meds. And so when the doctor says, "Are you taking this medication?" I say no. And the
Correct.
reason is that I can't afford it, and therefore I do not have them. So I'm, within a very short conversation, I flip from this green circle to the red circle. I'm
Exactly my
wondering,
point, Lucy. Yeah.
yeah,
And,
I'm wondering if there's
how consistent will we be in working that out when we're doing screening?
I guess I'm wondering whether we could possibly have a sequence here that would actually reflect reality better, produce better data, but not be too confusing to actually administer.
So I think a sequence
I
have
have medical material hardship because I choose not to buy health insurance and therefore I do not have any of this. Or I have medical cost burden that is so high that I'm ending up without any of this. That's a different sequence. The origin of the problem is different.
Yeah, and I do feel like this is where our screening questions and answers help lead us to this different thing, right? So, well, there's a comment here from an individual named Greg regarding the fact that there's a couple of LOINC answer panels that show up under 2 or more different domains, right? So, if you have a super general question, right, like that covers multiple domains, again, I think about that critical prepare question 14. It covers almost all of our domains. It's because it's like I don't have food, clothing, medications, right? So there's a whole host of cascading needs that result from that one question, right?
Mhm.
And it's everywhere across our model because it is, right? You ask that one question, you can end up in you can end up in medical material hardship, you can end up in food insecurity, you can end up in transportation insecurity, etc., right? Again, I think I guess I just want to hold space for the fact that we will have to see how this all goes forward. But I also want to state that this is the work that social workers and care managers and community health workers do all the time, like differentiating the primary driver and out of the identification of the social risks, right? These are all the things that are true, identifying the need, right? The specific thing. That's why we follow the Gottlieb and Alderwick lexicon, right? Like, so it's absolutely true I have a lot of medical debt. It's also true that I don't have my insulin. I need my insulin now, right? Because I'm super sick. So we'll have to see, I think, how this gets implemented. But as much as we're holding space for skepticism, I'm also holding space for I hope that our model of questions and answers assists with implementation. Yeah, so Greg, I know exactly. I understand. Again, that is so. I did know what you were saying regarding the questions and answer sets. So the questions, the less specific a question is, you will find it across multiple domains because if it possibly leads you to housing instability and homelessness, it would need to be on both. Whereas there are some questions that are only housing instability and there are some questions that are only homelessness. So not for the sake of efficiency and clinical efficiency, not every clinical setting can implement only specific codes that lead to specific things. So those meta kind of like macroscopic driver, like quick one questions, like that touch upon many things and then need further evaluation. They're really critical in busy clinical settings and social settings. So some of those codes are across multiple domains. Okay.
Sarah, this is Carrie. I just wanted to put a plug in for not shying away from things because we are afraid we might get bad data. As we implemented data collection on SOGI data in UDS, we got a lot of bad data, and it really just took education to help parse it out and get the right information in the right place. But because we have this granularity, now we have very good information on that. I think that's an important point to think about. And also, I think that obviously a person can have both of these things. One doesn't necessarily lead to the other. I can think of an example like when I had my son, I had to have a C-section, which ended up not being covered. And of course, the answer was that the hospital had financial relief. It did not lead to this medical material hardship where we couldn't afford medications and things like that. It may, but it doesn't necessarily. So I think they do need to stay separate.
Thank you, Carrie. Lucy, that's so sweet. Lucy is always offering it is a good problem to have data quality. I love that. Any other questions regarding this?
Yeah, this is Suzanne. Just a comment. I've really enjoyed, things that Lucy and those that are talking about how it'll be on, it may not be clear what's happening or one thing's going to lead to another. In Carrie's comments, I'm wondering if there is any part of what Gravity does that talks about a scenario or a pathway get one leading to another. I don't know. Is that part of Gravity's work as well?
So I do want to state that, again, it's on pause, sadly, because of our constraints. But making really logical pathways of how our different, so we've worked in the past and really have a desire to continue to work to give examples of how different patient stories and different screening questions and answers can lead to the kind of diagnostic outcomes that we're talking about. I really feel like those patient stories and those question and answer sets are incredibly helpful. Linda is working on something right now, Linda Hyde on the terminology team toward that end as well. But again, disseminating it publicly. Hopefully we can do this when we get more funding, but and kind of the feedback loops again that happen just because of the complexity of us being human and maybe, and these needs of course sit within other needs, right? So it's like maybe you are out of work because you have COVID, but you still have to pay your childcare because you have to hold your spot. And so suddenly that need weighs in here. So a whole other circle of needs that is not represented here on our slide right now. So, but we do have some kind of educational assist that we're working on, Suzanne. I hope that's helpful.
Yeah, it sure is. Thank you.
All right. Wonderful. Pastor, I always appreciated your comments there. Any other thoughts before we move on, and then we can pass the mic? We've used our whole hour for terminology here. Love it. Okay, next slide, please. No significant changes here. Again, very slim elements. We have the Carabello, we have Prepare, we have Medical Expenditures Panel Survey. Next slide, please. I do want to state that these are the aha moments that came out of our last public call, really questioning about the term excessive. And I did want to state, I think that was also our dear friend Lucy, who's so good at this. So really trying to integrate some of the terminology of the diagnosis itself. So burdensome out-of-pocket medical expenses and burdensome medical debt are the terminology in the hopper now to express kind of the heart of those concerns. And then you can see financial insecurity due to medical cost burden. This is a carryover from our financial insecurity work a year ago. And then the ICD-10 term isn't that existing financial insecurity term. Again, that we are happy to report is likely to be released on October 1st of this year. And again, the reason why we did this is because there were lots of different, the medical cost burden was conflated with health insurance coverage status in the fall, and our subject matter experts really asked us to kind of weigh in and make sure that we parsed those concerns for the public. Next slide, please.
This is a much better word, Sarah.
Burdensome.
It's not quite so constitutionally vague. It's what I feel, and therefore reportable.
Yes, exactly. Perfect.
Okay.
Cool. And then Mark, yeah, so they're already part of the public register, so you can see them, true, but they're able to be implemented very shortly. And
Can I
then,
add a comment on that, Sarah?
sure.
So it's the committee that actually releases them, and CMS publishes them as Table 6A on new diagnoses codes as a sort of a public benefit, but they're very clear in that they're not the ones that are determining it, and therefore they won't accept any comment on them because it's not their jurisdiction. So that's fine. They say October 1st. It's just an effective date, but it's the committee that actually releases them formally.
Thank you, Mark.
Yep.
So then we're going on to medical cost burden goal statements. So you can see that there's we've been working on the goals that might be aligning with medical cost burden. And so we're moving forward those, really the inverse of those burdensome elements. So no burdensome out-of-pocket medical expenses and no burdensome medical debt. So we have the burdensome in our problem statement, and we have the no burdensome as our goal statements. All right. Okay, and then next slide, please.
Sarah, what about help,
Oh.
able to find somebody to help me? Like there are a lot of programs often funded by, what's the word, Mark? Penalties on corporations, and they have to pay the state because they did something bad, but they're not going to jail. And that money then flows into community level, say, drug purchase programs. So from in the previous slide, one of the resolutions, yes, one goal could be where a social worker or a community health worker knows about a drug assistance program. One of the goals could be identify that program and get the person in it. Is that something reasonable for a goal here?
Well, I think that the meta goal would be the absence of the burdensome debt, but this is where our interventions come in. This is why those general interventions include the people and
Oh, you're right. Okay,
yeah.
gotcha.
Yeah.
Sorry.
No,
One
not
category.
sorry. No.
One category. Okay.
I realize we don't even have an intervention slide here. So sorry. In my making of the slides, we don't review the intervention elements. So you allowed me to talk about it, even though I forgot to make a slide for it. So. Because usually interventions follow goals, and we would have sat on that at our final slide. But this is if you could see next slide, our next slide is actually the questions and going into policy. So I'm going to pause for a second. We have covered our health literacy consensus vote. Again, votes are due by tomorrow at 5 Eastern Standard Time. The links are in the chat, and you can also send an email for them. And then also, we've talked about end-to-end review. There's a couple of comments people made. If you can send them, end-to-end review is currently for health insurance coverage status and medical cost burden. If you can send any comments to us by email, that'd be appreciated. And then we also have an action item to circle back with a comment from IHS just to support some of the questions that were raised here. And now, if anyone have any last questions, I'm happy and honored to pass the mic to my colleague, Mark. All right, Mark, take it away.
Thank you. I'll try to move quickly in the interest of time. So next slide, please. Gravity is advancing the work in many different policy spheres. One of them is the Interoperability Standards Workgroup, which is a work group managed by the Office of the National Coordinator. It is a sort of a subcommittee of the Health IT Advisory Committee. You've heard from me before on that, but just a little background for those who are new on this call. That work of the Interoperability Standards Workgroup is now in its phase 2. That phase 2 is focused on ONC's Interoperability Standards Advisory, which is a way of collecting and assessing interoperability standards and implementation specifications for use to meet interoperability needs nationwide. It is bigger than what you've also heard me talk about, the U.S. Core Data for Interoperability. That's just a piece of the kinds of standards that would be pulled together here in the Interoperability Standards Advisory as a sort of a proving ground where everybody can go and look for what might meet their needs for interoperability. And Gravity Project was invited to make a presentation to the Interoperability Standards Work Group on April 26th about recommendations Gravity might have for SDOH data elements and for race and ethnicity. So Evelyn Gallego and Asha Emanuel presented to the Interoperability Standards Work Group and covered, it was actually a surprise, all of the Gravity SDOH data elements are missing from the Interoperability Standards Advisory, even though they were integrated into U.S. Core Data for Interoperability version 2. So a pretty clear and powerful recommendation was to get all of that added, the data elements, the domains, the value sets, added to the Interoperability Standards Advisory, often called ISA, and to get our clinical care implementation guide added and our reference implementation. And not just the current ones that are published, but also the ones, excuse me, the ones to come. So for the clinical care implementation guide, it would be the one in ballot now, STU2. Also recommending that the source and method of collecting race and ethnicity data, which we have built into the STU2, the one that as a draft specification, the one that's being balloted now, also be included in the ISA. It turns out that there are important data elements that are where the preference is for self-reporting. Race and ethnicity are obvious. Gender identity is obvious. Disability status obvious, but often they're just clinical observations. So we are testing a method where we don't just collect the value alone, but we also collect the source and method of collecting the value so that people can know, was it self-reported or not? So we recommended including that as well. And finally, Asha gave a really powerful presentation on how Gravity's SDOH standards can be used to advance Black maternal health equity, sort of a use case to illustrate the importance of Gravity's standards, and that was all very well received. There hasn't yet been a final vote by the work group to make recommendations to the Health IT Advisory Committee. That will be happening shortly, but we wanted to report on it now because it's breaking news. Next slide. Oh, I see a question here. ISA mandatory. It's a resource. So while we might think of, Lucy, while we might think of the US CDI version 1 as being mandatory because it's in regulations, version 2 is not mandatory because it's not yet in regulations. ISA is just a collection for people to use as sort of a best practices, and so just a resource. But if you've got an important resource and you're not there, nobody knows to be looking for you. So it is very important to get it in there. Another way in which Gravity is moving social determinants of health data into action. The White House Social Determinants of Health Interagency Policy Committee asked us to make a presentation on the Gravity Project. This is a pretty significant committee, convenes 8 departments. One of them is HHS, so 12 agencies within HHS, and 6 offices within the Executive Office of the President. All of these are, the committee itself is sort of hosted jointly under the Domestic Policy Council and the Office of Science and Technology Policy. And on April 20th, Evelyn and I presented on the Gravity Project on the integrations to date of Gravity standards into federal policies and programs, and Gravity's letter and recommendations to the White House, which we sent on February 25th in response to a request for information. So you've heard from me before on that letter, and those are the recommendations we gave. The new thing at this committee meeting, besides the importance of being able to present broadly across the federal government, was to suggest a way in which the White House could accomplish all 4 of those recommendations with one relatively small initiative, which would be to convene 10 or 20 pilots nationwide using Gravity's SDOH standards to address locally defined population health equity challenges. And that model has actually been used before by ONC. In 2016 and 2017, I was providing technical assistance on the Community Health Peer Learning Project, which did that with 10 different community-defined population health challenges. And to great success, it was wonderfully well received and made a lot of benefits. So that was, we already had something in play as a way to suggest this to the White House, and we will see what happens. I have to say that invitation came in on April 13th, and we had a fabulous team-wide effort to get everything ready for presentation on April 20th. So tremendous thank you to everybody Gravity-wide for making that possible, and we are awaiting possible follow-up with Dr. Sandra Ford, who's the Special Assistant to the President. Next slide. And finally, 2 policy integrations with rules from CMS, Centers for Medicare and Medicaid Services. The first, you've heard from me before, I talked about the draft rule, proposed changes to Medicare Advantage special needs plans. That rule has now become final. It was published on May 9th. And indeed, they stuck with what they'd proposed. They will include standardized questions on housing stability, food security, and access to transportation in the special need plans health risk assessments. CMS will issue sub-regulatory guidance on what the questions actually should be, but again, clearly stated they intend to align them with Gravity's SDOH assessment data element in US CDI version 2. And they noted that, that while the special needs plan must address the results of the assessment in the individualized care plans, so for example, consulting with the individual about those unmet needs or making a referral, the special needs plan is not responsible, not accountable for resolving all of the risks identified. Just have to take it into account and fold it into the care plan. Next slide. Let's see, I'm looking at a question in the chat. So this is going back to the White House proposal. It was a high-level concept that we were proposing. If the White House is interested in something like that, I see your interest. We will certainly have more detail to be able to share, and we'll keep in mind that that there are probably more than 10 to 20 places around the nation that would like to do something like that. So thanks so much, Carrie. Will the rule align with the NC HEDIS? I don't recall, Mike, I don't recall a specific mention of that, but so if there's conceptual overlap, I would think, of course, but I don't remember seeing that. I know CMS is trying to get better about avoiding silos, but it's not always the case.
This is Mike.
Sorry, I don't have a better answer.
I'll unmute for a second, Mark. The issue
Yep.
is that in Michigan, at least, the health plans and the payers are already getting geared up to try to figure out how to implement the NCQA standard for asking the screening questions, which has specific language. And if that language is different under the CMS proposed rule, that just creates a lot of extra work for everyone, and it's relatively unimportant to have exactly the same precise wording in a screening question for a domain.
Understood. Agree. I'll give you an answer that perhaps suggests an answer, but it doesn't completely answer your question. There is language there about the desire to leave it up to the individual to pick for flexibility, identifying their own population and so forth. They will give guidance. For example, the guidance might suggest that that the SDOH assessment data element is a clearly recommended option, but not required, and sort of leaving it to what individuals have chosen. They don't actually say that. They say it's coming in a sub-regulatory guidance, so I don't know for sure, but I think there is some sensitivity to your concern.
Well, it looks like Sarah thinks that the questions will align, so that may eliminate the problem. Thanks for chiming in, Sarah.
second and final policy integration is a proposed annual rule just out. This is the annual rule on hospital inpatient and long-term care hospitals, and there is a proposal to improve health equity and maternal health outcomes, which includes 2 new proposed measures on screening for what they're now calling social drivers of health. So this would be an instance where CMS is not uniform across their rules. So the previous rule was social determinants of health. This is social drivers of health, and they are proposing US CDI to use the US CDI version 2 SDOH data elements as standard data sets. 5 domains mentioned there, 2 measures. One is the screening rate. How many times do they screen for one or more of these 5 social determinants of health domains? And the second measure would be a screen positive rate. And how many of those times did the individual identify a need? This would be voluntary reporting in 2023, mandatory reporting in 2024. Comments are due on June 17th. The rule also talked about the ICD-10 CMZ codes that we talked about earlier, in which Gravity had successfully submitted. The link is there. Finally, in this same rule, next slide, please.
Mark, is this for Medicare only or Medicare and Medicaid? Is this only for government? What is the scope of the CMS rule? Who does it apply to?
Hospital Medicare.
Thank you.
There's a request for information on social determinants of health diagnosis codes, or Z codes. And in the interest of time, I won't cover all of them, but you see the various subjects there. There's a range of topics where they're willing to entertain your expertise and wisdom. This is a request for information. It's not a proposed rule. So they will take into consideration the information from the community and consider that when they perhaps propose rules in the future, but it will not be a part of an existing proposed rule. And I think that's it for me, unless there are any questions. And see, we're short on time. I apologize.
Thank you so much, Mark. I did state this in the chat, but I do want to state that there is a lot of work recognizing all of the work and quality measures going on in the ecosystem. There is national work afoot to try to synthesize and standardize quality measure reports, and Gravity is part of those conversations on a regular basis. So just know we recognize the kind of cacophony of things, and we are working in the ecosystem to try to see whether things can be simplified.
Can I add one point on that, Sarah, which is we all, at the same time we're trying to do that, to be mindful that CMS is changing from ECQMs to DQMs, digital quality measures, and so we will have to be even more vigilant in trying to work that magic. Thank you.
Yes, wonderful. Thank you, Mark. And then unfortunately, we have only like 2 minutes for our technology report out. Next slide, please. Oh my gosh, I'm so sorry. There was so much to address. A quick little update from our technology team. So sorry, deep apologies.
1 minute more than I got earlier this afternoon.
I'm so sorry, Greg. Take it away.
Twice as long. Okay, so we continue to go through the ballot reconciliation process. I've updated the finish date for that now to be August 12, based on the number of elements we've been getting through every week. It's obviously slowed down a little bit of late, but we will continue to do that until we get through all of the process. You want to jump to the next slide, please? Okay, so we held the May Connectathon. We had 18 registered participants, with a couple of them trying to contribute, but the majority just being silent. We did test the specification from the perspective of demonstrating the reference implementation that was provided by HealthLX. One of our members, MaxMD, brought some code to test, but unfortunately didn't align completely with the specification, and so we weren't able to actually demonstrate that. Saffron Labs brought some mobile apps with the expectation that they would test against MaxMD, but due to that issue with the implementation, they weren't able to test. However, they did demonstrate closed-loop referral across a couple of different mobile applications. And the group also had some integration sessions with the Passio IG. Next slide, please. So there is an upcoming CMS Connectathon for July. So we would love to encourage as many people as possible to join us for that. I've included the registration link on the page here if you need it, but feel free to join up and come join us. Next page.
Oh my word, we did it.
There you go. Right on 5:30.
Oh, I love it. Okay, so what a tremendous presentation today. Oh my word, our work. It's so broad and necessary. Thank you, friends. So always catch up, submit that vote by tomorrow, 5 p.m. Eastern Standard Time. End-to-end review, we have one more session. This is it. So submit those end-to-end review comments for medical cost burden, health insurance coverage status. Sign up for the Connectathon. We got the comments on trying to make some of those policy elements consolidated. I believe we can do that probably on the Confluence. Thanks everyone for your collaboration and participation. And we are so, so grateful for the collective, and we will see you in 2 weeks. Thanks so much.
Bye.